Good evening. My name is Kathy Poole, and I'm the Director of Marketing and Community Relations for Nashville General Hospital. Welcome to our Community Conversations Virtual Roundtable Series. This evening's topic is Minority Health Matters. April is Minority Health Month. The term minority health is often used to describe racial, ethnic, and underserved populations or communities. The goal of our virtual roundtable is to raise awareness about health disparities that continue to affect people from racial and ethnic minority groups and encourage action through health education, early detection, and control of disease complications. Joining us this evening are Dr. Faye, an optometrist here at the Nashville Healthcare Center, Dr. Kevin Billups, a men's health physician at the Nashville Healthcare Center, professor of medicine and urology at Meharry Medical College, and director of Meharry's Men's Health Program. Ms. Kristen Clarkson, director of the Congregational Health and Education Network. Hopefully joining us soon will be Dr. Tora Long, our family medicine physician at the Nashville Healthcare Center, and then Dr. Adrian Sanders, pharmacist and a certified diabetes educator. And last but certainly not least, please welcome our Minority Health Roundtable moderator, Ms. Kaylin Harris.
Thank you, Kathy. And as Kathy said, hello, everyone. My name is Kaylin Harris, and I am the multimedia brand designer here at Nashville General Hospital. Nashville General Hospital is our city's original community hospital with a mission to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care. Essentially, that just means 100% access and zero disparities between populations. The publication Healthy People 2020 defines health disparity as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation, or gender identity. And the list goes on and on. Our focus today will be on racial and ethnic disparities to highlight Minority Health Month. According to the CDC, approximately 40% of the US population belongs to a racial or ethnic minority group. Minority health matters, and we are here to discuss health disparities of minority populations by minority providers. This is not just a roundtable discussion, but a community conversation. So please feel free to ask questions through our Facebook Live chat, and I will incorporate them into the discussion. So without further ado, let's begin. So Dr. Billups, the first question comes to you. So from our knowledge, from our research, you are actually the first, or you were the first African-American to complete the urology residency program at the Johns Hopkins Hospital Brady Urological Institute. My apologies. So how important is it to have healthcare professionals that look like their patients?
Well, thank you. It's a pleasure to be here. And you actually said that just right. So you said Brady, right? So that was fine. It's very important. I think it's critical. I mean, honestly, I hear that all the time. That the importance of having doctors that look like you. And I'll speak mostly to men's health, because that's all I do now. It's all I've done for the past 30 years. And I can tell you a lot of my patients will tell me that there's a certain comfort level in seeing them. And we certainly need to get as many African Americans in the health profession. I mean, men are becoming a dying breed in terms of becoming physicians. So we really do have to do a better job of that. We need more African American and minority physicians in general, but especially among men. So I can tell you that. So yes, I think it's critically important.
Thank you very much for that. And then definitely, and I know that you spoke about now you primarily focus on men's health. So if you don't mind sharing, so what are the disparities, or what do some of the disparities look like when it comes to your specific field of medicine?
So my practice is it's a men's health practice, but it's focused on preventive medicine. So I used to call it like gynecology for men because I do a lot of erectile dysfunction, low testosterone. But honestly, it's preventive health for men. I use the sexual health piece to get men engaged into the system. But really, what we look at are the major problems. So I'll just diabetes, high blood pressure, heart disease, stroke. And so I can briefly mention it. I know we're all familiar with these health disparities, but if you look at diabetes, 50% of the U.S. population has diabetes or pre-diabetes. But if you look, African Americans are about 60% more likely to be diagnosed, and so it's much more common. I think about twice as likely to die from diabetes. High blood pressure is another one that I see all the time. Again, if you look at the general U.S. population, it's about 50% of people who have high blood pressure. We know it's higher in the African American population. You can look at heart disease. That's more prevalent there. You can look at obesity. Being obese or being overweight. All of these lead to conditions like heart disease, stroke. Stroke is more common. I think if you look at African American men, we're about 70% more likely to die of a stroke than others. So you can look at renal disease. So there's a number of chronic diseases that are really causes of not only morbidity or just not doing well, but also death and mortality.
Well, thank you. Thank you for sharing, Dr. Billis. Thank you very much. So with all of that knowledge and expertise, I'm sure you're going to, I hear whisperings that you have a clinic opening up soon.
Yes, so we have a new clinic opening up in the 1919 building on Charlotte Avenue, and we're really excited. We're actually up and accepting patients now, and the first actual day will be a week from today, next Thursday. So we're looking forward to it. I mean, I think it'll be a chance to impact a lot of people. We see people. I do a lot of telemedicine because men don't like coming in the office, so telemedicine is actually a good thing for all of medicine, but especially for men's health. So I'm looking forward to that.
Well, thank you. Thank you for sharing, Dr. Billows. And it is very important. I think a lot of times, especially when you think about minority health, it can be an uncomfortable conversation. I think for especially the population in general, I guess I should speak, it can be an uncomfortable conversation, especially when you think about sexual health. And a lot of times, their men and their female partners, they're usually the one making the appointments, making the calls, taking care of the prescriptions and everything. I see all the women on the panel shaking their heads, yes, and smirking. So I think that's definitely a great opportunity to see you not only on this panel, but sharing what you do, but also letting them know, like, no, there is a friendly face. I do look like the people that I'm servicing in this community and welcoming me in. So that's great. That is great. I'm excited. And the next question that we have is for Dr. Faye, because as we know, eye health is also an important part of preventative care and maintenance of our overall health care. So can you share, Dr. Faye, how minority populations can lower their risk for eye disease? And are there any particular eye diseases or particular things that you see when it comes to minority patients that come in?
Definitely. And once again, I'm happy to be a part of this roundtable discussion. Definitely important to share as much knowledge as we can about how we can better take care of ourselves. So well done. There are too many eye diseases that disproportionately affect minority populations. The biggest three being glaucoma, diabetic retinopathy, which is disease of the retina due to diabetes, and hypertensive retinopathy, which is disease of the retina due to hypertension or high blood pressure. Starting with glaucoma, that is the disease that is probably the scariest because that is one disease that an individual can have and they would never know. And often by the time someone is finding out for themselves, it's often too late. So in regards to glaucoma, that is definitely something that has to be seen by your doctor. They are the ones who are going to make that diagnosis and be able to see what's going on in your eyes, what's going on with your vision. So to lower your risk, it's as easy as getting an eye exam, getting a comprehensive eye exam. one that is going to check the health of your eye front to back, and also look for those signs or risks that you could develop glaucoma later in life. And a lot of times those risks are related to your age. So number one, being a minority, especially if you're African American, you have you're 6 to 8 times more likely to develop glaucoma compared to any other population. That is compared to everyone else. So that is a disease that very much disproportionately affects people of color, specifically Black people. So that is something I see daily. I mean, I can literally every day, there's not a day that doesn't go by where I'm at least having a discussion about glaucoma. Not necessarily that you may have it, but these are the things to look out for. With diabetes and high blood pressure, those are diseases that we of course know affect our body head to toe in many different ways. But with the eyes, that is something that is preventive, of course, to reduce our risk of developing eye disease related to diabetes or high blood pressure. We have to control our blood sugar and blood pressure. Trust me, it's easier said than done. I know it's something that is difficult for many people to manage, which is why it's important to partner with a doctor that you trust. Oftentimes I hear from my patients that they're just so happy to see someone that looks like them. And it allows me to engage with them in a way that they might not have had with any other doctor. And even as an eye doctor, I am having these discussions about how can we better control your blood sugar? How can we better control your diabetes, high blood pressure, or anything else that we can see that may affect your eyes? And I'm also partnering with your primary care doctor to have that discussion about what can we do better to improve your eye health. Aside from those three things, just getting a regular eye exam at least once a year is recommended. Also protecting your eyes when you're outdoors. So wearing sunglasses or protective eyewear if you tend to work with objects that fly or chemicals that may splash, definitely taking the measures to protect yourself. And also moving, staying active and eating a healthy, balanced diet is going to go far in terms of keeping your eyes healthy.
Thank you, Dr. Faye. And I was actually about to ask you the question. So like, how often would you say, what would you call a regular eye exam? Like if someone starts to work with their primary care provider, or if someone finds themselves uninsured and in between processes. So would you say twice a year, or if they start to see certain symptoms and effects, would you say a little bit more?
Yeah, it's definitely recommended. Anyone over the age of 40 to have an eye exam once a year minimum. That may become more frequent if your eye doctor finds any type of eye disease that requires more, ongoing monitoring, or if you've been started on any medications. There's some patients I see them every 6 weeks, and I love it. Some patients I see them once a year. So, and that's a discussion to have with your eye care provider. How often should I be coming in? Is once a year enough? Should I come in more? Or in some cases, I spread it out to 2 years, depending on how stable or how healthy things are for you. But it's definitely recommended at least once a year. And oftentimes you don't have to wait to have a primary care provider to be seen by an eye doctor. You can also see either one first, because a lot of times I might see things that I'm having you establish care with a primary care provider if you don't already.
Perfect. Well, thank you. Thank you for all of that. And I do have one more question for you that has come in. So I know generally we have the conversation, or generally in some households, it's the, debunking some myths when it comes to your eye health. So eating carrots. See, everyone laugh because everyone's mom and grandmother told them, eat your carrots, your eyes are going to get stronger. So can you is that true? We want to hear it from a professional.
It's true. Granted, you would have to eat a lot of carrots, but it is true. Carrots actually have a component called beta carotene that's actually proven very beneficial to the eye, specifically to the retina. So definitely eat your carrots.
Thank you. Thank you. So Dr. Sanders, Dr. Adrian Sanders. So as a pharmacist, so as we talk about, I feel like with this panel, we're kind of going through all of the senses. So we spoke to Dr. Billups and he talked about the physical health. We talked to Dr. Faye when she talked about your sight and your vision. I know we'll talk to Kristen a little later about your spiritual health. So now we're getting over to you when it comes to pharmacy and, big pharma, as people like to call it sometimes, but that's when you get more into what you digest and you take in. So as a pharmacist and a certified diabetes educator, is the minority population at a higher risk for diabetes?
Thank you. Got a little comfortable. Sorry. It's good information. Thank you, Kaylin. It's a pleasure to be a part of this panel, and it's just a pleasure to be here. So minorities are at risk, and I was hoping to get some information here, and I don't have the exact numbers here, but and it's diabetes is complex, but the minority aspect of the let's see, I guess where it can be such a it's more prevalent, I guess, amongst minorities. It can be environmental and genetic, and so while we inherit our eye color and various things, that's genetic. And then there are some environmental things that disproportionately affects minorities, which could be access to health. It could be, we talked about debunking or dispelling myths, and that could prevent someone from just taking good care of themselves. There's also there are cultural I guess preferences, or there are cultural behaviors that could serve as barriers, and I think when it comes to lack of healthcare and distrust, that can seem to worsen diabetes, which also ends up being heart disease as well, or just because you're about 4 times the risk. So you manage the diabetes and the heart health too. And so amongst my minorities, because of those reasons, then it's compounded with just the other risk factors, which could be overweight, or a poor diet, or being in what's called a food desert, and being physically inactive. And not all minorities are physically inactive or overweight. These are just things that are on top of the perceived distrust or lack of access and dispelling myths.
Well, thank you, Dr. Sanders. And I guess I know generally when we think about, I guess a lot of times in the minority community, when we think about diabetes, you think about, these are decisions that you made in your youth that ultimately impacted, you only get diabetes when you're 40 plus. I only have to worry about diabetes when I'm, later on in my life. I can have my fun. I can eat all my cakes. I can sit at home. We're in a very, what's the word? Everyone's in their work from home phase. So I can sit at home, watch streaming services.
Mm-hmm.
So I guess to debunk that myth, does diabetes have an age group that it primarily affects in the minority community? Or is it something to where, right now in your 20s, you should be, making the strides and having good, healthy habits to prevent diabetes later on in life?
Well, just getting older is a risk factor. I mean, just over, I believe it may be 45, and according to the Association of the American Association of, the ADA, the American Diabetes Association, excuse me, there is I think it's as of this year, there the screen is at 35. They're screening at 35 instead of 45. So getting older is a risk factor. But part of what my hope is, part of what we can do differently is as we talk more, and all of the providers on this panel practice evidence-based medicine. And when it comes to sharing information, mama had it, grandma had it, and just because they had it, that doesn't mean that now there's a genetic factor. There are things that are preventable. And so you mentioned in your youth, now type 2 diabetes, there is about a 10-year, it takes about 10 years for the pancreas to, I guess, alert our bodies that it's there. And so type 2 diabetics tend to have more comorbidities, or they walk in with more comorbidities, excuse me, as opposed to the type 1 diabetic. It usually comes earlier. And so just not to elongate the answer, but getting older, it is a risk factor, but the things in your youth, I mean, when this is with the lifestyle, especially talking to the elders and talking to your family members, and type 2 diabetes can be preventable or maybe even delayed. And so lifestyle can actually prevent or delay type 2 diabetes.
Thank you, Dr. Sanders. Thank you very much for your response. And now we have Miss Kristen Clarkson. So Kristen, as the director of the Congregational Health and Education Network, how can our faith leaders in our local community, or anyone who's viewing virtually, how can their faith leaders impact the health of their congregations, especially in African-American communities?
Right. Well, hello. I would say the faith community is an integral part of the African-American culture. So, the status of the church as a pillar in the community makes it an ideal setting for reaching and teaching the people, especially due to the trust that's placed in the church and its leaders. These faith leaders have communication skills, they have knowledge of the religious doctrines, and a cultural competence that positions them to really understand the unique challenges of their congregants. Faith leaders can really impact the health of their congregations at both a group level and an individual level. At the group level, sorry, see me coming in and out here. At the group level, scriptural messages and instructions from the pulpit have been known to influence health behaviors. So saying, the body is a temple of God and thus should be treated well and with respect is something that's respected within the church community. Many churches have a health ministry that at an organizational level will instill or reinforce a lot of those social norms and cultural traditions that can promote positive health behaviors among the church. And that's backed up by the social nature of the church family. So something as simple as having a Bible study and asking people to show up 15 minutes early, and you all take a few laps around the parking lot. Just walking, just getting people moving where they normally wouldn't is a good start to a healthy habit. At the individual level, of course, again, that trust in that faith leader, having one-on-one counseling with people that they have a more personal relationship with is helpful, or those that may feel more comfortable speaking about their issues in private. They don't want a group setting. So being able to go to someone and have those conversations is a stepping stone to connecting them to services that they may need. So reinforcing those personal relationships will also influence those behaviors. And also, people look to those pastors as a pillar themselves. So, they may say, you might hear someone say, well, I don't want pastor to know I went out to the bar, or, that I was smoking, or, or went and put themselves in a situation that they know they really shouldn't have been in. And so they don't want pastor to disapprove of what they're doing. So by default, they may not engage in some of these riskier behaviors or avoid them so that the church leaders don't find out. So whether they realize it or not, our pastors and faith leaders really have a great deal of influence when it comes to the health of their congregations. And I would say that the best way to do that is to lead by example. So exhibit those healthy behaviors themselves. If they're going and getting their regular checkups, they're speaking about health, then the people that they lead will follow.
Thank you very much, Ms. Clarkson. And I think that, and to your point, like when you do think about, I mean, I can only speak for the religion that I practice, but I know in different conversations with different fellow employees here at the hospital, every religion does have health tied into its doctrine, or has, speaks about in their literature. They talk about, healthy programs, or just the ways that the body is a temple is just a universal term that I'm sure that we've all seen in some capacity. So I love how you tied all of it together, because it is a huge point, your spiritual health and the way that what you practice and how you treat your body and how you speak to yourself is a really great practice to have, especially in the minority community. Because I think a lot of times, church is interwoven into, kind of like what Adrian spoke about, your great grandmother and your granny, and then you got your mom. So you're pretty much learning these habits and learning these different, I guess, phrases and verses to teach yourself. So that was really good. But you did speak about, that trust when it comes to your relationship, when it comes to speaking about your health. And I know Dr. Billups, early on, when you talked about men's health, you did mention that a lot of times men you do telehealth, because you may have some patients who aren't really fully comfortable sitting in a waiting room. It can be awkward sometimes when you're going to go see the doctor, depending upon the conversation. So I wanted to ask all of you, what does that look like for you when you're having those conversations with patients, or what is some advice that you would give, or even just some helpful words of affirmation that you would give to some of our viewers for if they're going to go speak to any of the providers about this information, to kind of not only build that trust in the healthcare system, but also, to kind of help them ease their souls and spirits with that process. And anyone can answer. This is free to everybody.
Well, I guess I can go first there. So I think that you're right. The trust factor, putting the patient at ease and comfort is important. So I encourage people, you should ask your doctors questions. I mean, because, and we should be able to answer and we should be able to answer them in terms that you understand and provide that. So I think that, that's something that I would encourage people. But even I don't, have things written down, because you get in there and you get flustered, and you might forget. But I think that's important. So that's what I encourage all my relatives to do, so they can ask their doctors. Otherwise, I get asked the questions when they come out. So I'll stop there.
Thank you, Dr. Bill. Anyone else? Does anyone else have anything to add?
Yes, Kaylin. If I were to, as I do talk with my patients, or the participants, it could be of an education program, is to identify their why. Just because with us all practicing patient-centered, we have to identify their needs, but we also have to understand their experiences and their circumstance. But it's just identifying their why. And part of diabetes, and with diet and lifestyle is such a big part of it. If you were at the event with a table of all of these foods, whether it's a holiday or some type of gathering, you just have to make a decision. What is important, I guess, really, and so I would just really encourage them to identify their why. And it could be simply because it's best for me. It could be, I have a husband and children. I want to live to get old, or, whatever the case is. But that's part of the conversations I have for the diabetes in distress, after I, listen to them.
Thank you, Adrian. Thank you, Dr. Sanders. Dr. P.
Yes, for me, it's always listening to the patient, being open to listen, but that also requires the patient to feel comfortable enough. And I think sometimes as providers, we can get into the routine of not really pausing to look at the person in front of us, see them as a person and not a patient. So I'm very mindful of that. And I explicitly tell my patients, hey, I'm here to partner with you. Because a lot of times I recognize people are coming in, they're already feeling some level of shame or worried about getting bad news or I messed things up. And sometimes just easing into that conversation of, hey, by you showing up, you're already taking the first step to take care of you. So now it's my opportunity to partner with you to meet your goals, whatever that may be. So it's one of those things where I try to keep it at the forefront of my practice, just really recognizing that I'm here to partner with you. I'm here to make recommendations with and for you. And you ask me those things. You challenge me as your provider. Am I doing the best thing for you? Is there something that we need to be looking into? But definitely writing those questions down, because when I'm a patient, I forget things that I want to tell my doctor. So writing those questions down, and don't be afraid to limit that interaction to that point of your exam. Be open enough to say, hey, I have a question, can I call the office or leave a message? And just be aware that that care continues beyond that exam.
Thank you everyone. And I think that this is a good segue into just to remind our live audience that you do have the opportunity to ask questions for our live panel right now in our Facebook live chat. And we actually have 2 questions that have come in. So Dr. Sanders, this one is specifically for you. What can be done to prevent diabetes? You mentioned that lifestyle changes but can you also expand on the major areas of lifestyle?
So there is for my panelists, the providers on the panel, there was a trial amongst the providers, the healthcare providers, and it's just a DCCT trial. And it just basically proved, and this is for the pre-diabetic, which can be identified. And I know that this is not the major part of our conversation, but therapy begins there, and not necessarily with taking a tablet. But in the study, there's a weight loss of roughly 5 to 7% of your body weight can delay or even prevent the further diagnosis into diabetes. And so the lifestyle, including exercise, this movement, and I believe it was Ms. Clarkson, simply walking, getting, that moves, just getting moving. There's visceral fat that we can just shake up, just by moving. But it would involve a certain way of life as far as eating. And that's just whether it's carbohydrates, and that's something that the dietitian or another provider could talk about. But it's all about what you eat and just how much movement you can make.
Thank you, Dr. Sanders. Thank you. And we have another question that's come into our live Facebook chat. And viewer, please forgive me if I pronounce anything wrong, or any of the providers and healthcare professionals, please do not get me for this. My degree is in marketing, so but I'm going to try my best. So the question asks, are there minority-specific psych or psychoid around diagnoses of diabetes? And also, does life stage influence this? Thank you, viewer. Psychoeducation. Thank you for viewing and knowing that I did not know what that abbreviation meant. Let's start over. Are minority-specific psychoeducation, or is there minority-specific psychoeducation around diagnosis of diabetes? And then also, does life stage influence the psychoeducation approach?
Are you saying life stage?
Yes.
Okay. Okay. Now I would actually, that's something that I don't think I can answer in the totality of our very kind viewer. However, the American Diabetes Association, the website, it's an excellent and free resource. That's for the consumer or the professional. And on that website, there's just a plethora of information that would start from risk tests, sample diets, psychosocial. There's some psychosocial articles there, and so someone with diabetes, I'll put it that way. I guess we can just not, shame is something that diabetics deal with first. And then there's also the distress of something that you live with every day. And then there is fatigue. I think it's called dread, and that is not the actual word dread. The DRED, it actually stands for something that I know I'm going to miss, so I won't actually say it right now. But which pretty much warrants the need for ongoing support. And so part of my role as a diabetes care and education specialist is to perhaps fill in those gaps for the providers I work with, just because that can actually, just say, for someone who is maybe not quite at the stage of accepting, or maybe, because you get angry, you have all kinds of feelings, and there's a variety to where I would hope to be able to help them and alleviate the discomfort. But that website would be the first place I would check.
Thank you, Dr. Sanders. And I wanted to open up the question to the entire panel. So we've all, to a certain degree, just, have talked about that relationship building, essentially. Everyone had an opportunity to speak about how important relationships and trust builds a better bond between individuals in the healthcare community, and with our, individual members are in the healthcare community. So I wanted to ask, what things, or what have you all seen, or what have you all done to reach back, essentially? Because, the healthcare community, there aren't many people of color, Black and brown people within our industry. It's growing. Numbers definitely look different than what they used to. And I think, there are a lot more female providers than what there were just 10 years ago. There are a lot more women in healthcare. There are a lot more Black men at a certain level in healthcare. But, what relationships that you all build, even Kristen, with you and spiritual health, what relationships that you all build that ultimately led your decision to where you are now? And then what relationships or mentee partnerships have you formed that you're like, okay, this is my opportunity to pull forward and give back?
Well, of course, in being the director of CHEN, the Congregational Health and Education Network, we like to consider ourselves kind of that connector organization. So we leverage that trust that we have with our faith communities and with these churches within our network, and we bring them resources. We're essentially we're a vetting process for them. So they know we're not going to come to their doorstep with anything less than the best. If we're going to tell you to go and visit Dr. Billups' clinic, it's because he's the best at what he does. And we know that he's going to provide care that is above what you're going to get anywhere else. We hear a lot of times people come in and say, well, I went to such and such hospital, or I went to such and such clinic and I had a bad experience, or they rushed me out, or, I didn't get to say what I needed to say. And so we're going to guide them to places where you're not going to get that. We're going to guide them to resources in the community. We're going to guide them to educational opportunities, because we feel like getting a better education will help you. It's the underlying source of a lot of these disparities. So getting a better education leads you to maybe getting a better job, and that gets you access to health insurance, which increases your access to healthcare. So we're connecting them to the opportunity to not only improve their health, but to improve their lifestyle. So it has far-reaching opportunity there. So we like to connect, and like I said, we come with only the best of the best, and we really do care about the people in this community.
Well, I guess I can go next. So in terms of reaching back, I'd say the two groups that I focus on a lot now, one would just be the general public patients. I mean, and we really try and focus on education, engagement, and empowerment, because especially, again, I speak mostly about men, but this is true for everybody, I think. Empower people act. And the biggest thing with men is we can't get men to come into the office, and we just can't do. We have the mindset of just not doing what's right, taking care of ourselves. So we really don't practice self-care. But education is very important there. And everybody, we talk a lot about lifestyle, which I 100% agree with. Lifestyle could really get back into. Lifestyle could probably put us out of business as healthcare professionals, or really minimize what we do if it got to that stage. So that's one group. I really think you have to focus on the public. The other group that I spend a lot of time now are the medical students, especially the first and second year. Really more the second year medical students, first and second year, because they're still impressionable and they actually listen. Unlike a lot of us that have been out there for a while, we're kind of set in our ways. But you can really introduce new ideas. They're eager, and you catch them at a very young age. So those are the two groups I really focus on now. I probably focus more on that than I do on peer-to-peer or other provider education, because I think that'll make a bigger difference in the long run.
Thank you both very, very much. And I wanted to ask, so essentially, our entire conversation is about minority health matters and why minority health matters. And, we've spoken, or threaded into our conversation today has been about having someone that looks like you on the other side of that table. And I think that helps with that mistrust as well in the health community. I know for myself, moving away from home and moving to Nashville and being on my own health insurance. But I was dead set on, I want, Black female providers. I want all my providers to look like me. Like, I want to be around. I want a healthcare team that looks like this. So I wanted to ask you all, even for yourselves, like, how important was it, and whether it's and it's twofold, whether your decision to enter into this industry, was it geared towards like, okay, I want to make sure my patients feel comfortable seeing someone that looks like them on the other side of the room? And then in turn, has it been important even in your life to have a healthcare team that looks like you as well? And that's for anybody.
No, I'll go. I think for me, it was the information. And so, we talked about things that can be passed from generation to generation. And, since on this particular panel, we talk about diabetes, that's something I'm sure we all say charity starts at home. Being on both sides of my children's families, that's something that they're quite aware of. And so proceeding with awareness, just so we can know what to do. You have the information now you know what to do. They're responsible for that information. But as far as healthcare provider, someone, I'm looking for the information. I know for me, we mentioned earlier, evidence-based, progressive medicine. Somebody's going to give me the truth with solutions. And it was less important that they look like me, I have to admit, but I found a lot of success in providers who look like me and giving me exactly what I need.
So I'll add on that. In terms of going into medicine, I went into medicine because I was good in math and science, but I did have, growing up in Baltimore, there were two African-American pediatricians who kind of took me under their arm and kind of introduced me to some of the clinical lifestyle, introduced me to some of the research lifestyle. So that was important. The other thing, though, I'll add is having mentors that look like me. So Dr. Levi Watkins, who is well known. He was the first African American to finish Vanderbilt University, the medical school, and then he was the first African American to finish Johns Hopkins cardiothoracic program. And he single-handedly turned things around at that medical school. But having him as a mentor, and I tell my students that now. I said, seek out mentors who are going to be in your corner and help you, because I could not talk to Dr. Watkins for a year or so, and if I needed something, I'd call him and pick up the phone, and it'd be like we never left off. So besides just actual positions, I think what we need are mentors to really take these kids, and that's another reason why I like interacting with medical students, because if I can help them not make the same mistakes and not stress out the same things I stressed out on, then that's a good day. So I just add that to it. But I agree with everything that's been said.
Yeah, I would definitely agree with mentorship. I would say as an optometrist, there weren't many, if any, optometrists that were Black or Black and female. So my first interaction with a Black female optometrist wasn't until college. But luckily I had mentors that may not have looked like me, but they instilled a level of confidence in me that, hey, you could be the one to be that person you needed when you were looking at what you wanted to do or what you could see possibility in. So for me, that was my driving factor, like realizing that I might be the first to do something. So looking back, and even now, I've realized how important it is for me to be present. A lot of times, even with my patients, they might mention, like, ask, how long do you go to school for this? Or I might talk to their daughter or son who's there, like, hey, you thinking about school? Where are you thinking about going? What are you thinking about doing? Come and shadow me, see what you like, see what you don't like, or even introduce you to something that you may not even have thought about. It might not be optometry, it might be something completely different. And I encourage that. I don't necessarily want everyone to be an optometrist, but I want them to see possibility in areas that they might not see themselves in because they don't see someone that looks like themselves. So that for me is a big driving factor. As far as a patient, it was important for me to have somebody who just listened to me. And I found the best luck with minorities. I've got, if I think about my care team, I've got Indian, Middle Eastern, Hispanic, African American. I've got literally probably the United Nations when it comes to the people who I'm entrusting with my care. And I tell my patients, hey, if there's someone, regardless of what they look like, if there's a level of trust that you feel like you're not having or getting from them, don't be afraid to change. Don't be afraid to move on. Don't feel stuck, because you have to realize this is someone who you are going to be entrusting with your health and to some extent your livelihood. So not being afraid to ask those questions that get you to a level of trust with your provider.
Okay, perfect. And then we have one more question before our time is up. So one of our live viewers said, let me scroll back to the comments. Prevention awareness seems to be a problem in the African American community because there are still some people that fall into that spectrum of being overweight. So can you comment on, I believe maybe this is a question geared towards Dr. Billups and Dr. Sanders, but can you comment on prevention awareness and if we are making any headway in that specific area? So even though, and then for our viewer, even though your question specifically speaks towards people that fall towards a certain end of the weight class spectrum, I would also want to frame it as prevention awareness in all of the areas that we kind of discussed. So I know Dr. Faye, we talked about, debunking the myth about the carrots in the eyes, but even Kristen and you also spoke about, viewing more so like our spiritual leaders as they're pillars in the community and viewing them as a resource for health. But yes, whether Dr. Billups or Dr. Sanders, if you would like to close us out by answering the question.
I can go first if you want. So the viewer is absolutely right. I mean, that's kind of the holy grail, the preventive approach. So, and I, you know, I used to think, especially with men. I mean, if you tell a man, I have a clinic, I'm gonna do a great preventive workup on you. All you need to do is come in. We like run the other way. I mean, that's a sure way not to get somebody to come in. So I've shifted my approach for men. And after I listen to what's going on, I'll ask them two questions. And I'll say the first one is, are you curious about your health or are you serious about your health? And I let them think about that and answer. And then usually they'll say, well, I'm serious. And then I'll say, are you willing to face the things that are making you sick? And then if they answer, yes, I am, then I say, okay, well, then I can work with you. And not only, can I improve your health, but I can transform your life if you're willing to do those two things. And those sound like two simple questions, but they aren't really two simple questions. I mean, and then the next thing I tell them is, one of the first things I need you to do is you're going to have to level up around your lifestyle, because 80% of the guys that come to see me have something wrong with them. They have diabetes, pre-diabetes, high blood pressure, cholesterol, overweight, the abdominal pain. So they have 3 or 4 of those things that are going on. So that's the conversation I have to try and get them focused on prevention right away. That if you address these things, forget about trying to lose weight. If you address your metabolic health, everything else will follow. So the viewers is right. And there's no easy answer to that. But for men, I just have to where I'm just going to challenge you, because men like challenges, right? You can back down if you want. And if you don't want, then I'll say, well, maybe this practice isn't exactly what you need, right? If you want somebody to just throw you on medicines, and because medicines treat a symptom, a medicine does not get to the underlying cause of what's causing all that. So I'll stop there.
Well, thank you. Thank you, Dr. Sanders.
I was really just going to say, I just agree. I agree with them. Just 100% is willing to do something different. I mean, especially just like Dr. Billings, he asked the question, are you willing to do this? Based on whatever the situation was, or he asked if they were willing to do this based on what he just told them. And if the patient is, or our friends are willing to do something different, then I think that would actually speak volumes to prevention. And what I mean by something different is, just as far as sometimes you just can't do what everybody else is doing. And that's what I mean by that. And that can probably involve another conversation.
Well, thank you all. Thank you all for your discussion.
Yes, some very enlightening discussion indeed. And Dr. Fahy, I appreciate you pointing out how, you talked about the United Nations, because minority health includes people such as myself, which I'm part Filipino. So, there were many medical issues my mother had because it was cardiovascular issues. She had a thalassemia trait that was very specific to Pacific Islanders. So me going into a doctor's office and making sure that they understand, what I am and what I'm not, to be able to help me navigate that as I go down my own health path. So this is unfortunately all the time that we have. We do thank everyone for being here. Any questions that are in the chat, Kaylin will make sure that those are answered. Even if they come in later on, we'll circle back to our providers to make sure that we have responses. I also want to take a moment to mention that this is Black Maternal Health Week. Black women are 4 to 6 times more likely to die from pregnancy-related causes than other women. President Biden on April 8th sent a proclamation calling on Americans to raise awareness of the state of Black maternal health in the United States by understanding the consequences of systemic discrimination, recognizing the scope of this problem and the need for urgent solutions. Amplifying the voices and experiences of Black women, families, and communities, and committing to building a world in which Black women do not have to fear for their safety, their well-being, their dignity, or their lives before, during, and after pregnancy. We are especially saddened here at Nashville General on the passing of our own Black health women's champion, Dr. Gwinnett Latson. She's the former chief of OBGYN at Nashville General Hospital and instrumental in the Black maternal health in the Nashville community. We ask that you please keep her family, her work family at both Nashville General Hospital and Meharry Medical College in your prayers.
Thank you, Kathy. And I would like to again say thank you to everyone that joined our community conversations, another series of community conversations on this evening. We really appreciate everyone that joined live and virtually, and all of the questions and great comments that we got in the chat. And again, as Kathy said, if you have any questions for any of our panelists at a later date, or if you watch this recording 2 weeks from now, please feel free to continue to comment. All questions will be shared afterwards with our panelists to make sure that they are answered. And we definitely want to give flowers and virtual flowers to all of our panelists that joined us today. Thank you, Dr. Billups, Dr. Fahey, Dr. Sanders, and Miss Christine Clarkson. We really appreciate you all for joining on. And shameless plug, if you would like to see more of Kathy and I, if you like to see more of our lovely faces, and all of our panelists now have all in some way been on one of our segments or sessions. If you'd like to check out any of our past Wellness Wednesday series or community conversations, please head to the Nashville General Hospital YouTube account to find out some really great information and hear all of these individuals talk a little bit more specifically about their individual industry and their part of healthcare. But without further ado, we will bid you all good night. Have a great night, everyone.